Well, if we've learned anything from these past couple of years, my fellow Americans, it's that personal medical freedom and liberty are in crisis. America Out Loud Pulse brings together the top experts in healthcare-related fields to keep you a beat ahead.
Welcome back to America Out Loud News. I'm Dr. Mary Talley Bowden, a Houston-based ear, nose, and throat and sleep medicine specialist. Today we're going to talk about vaccine injuries. We're going to bring in 4 experts to tell us what they're doing to help these complicated, challenging patients. Unfortunately, I'm still seeing new patients coming in on a fairly regular basis with injuries. Typically, they've seen multiple physicians, they've had multiple tests done. Other physicians are basically throwing up their hands and telling them we're not sure what's happening. They're, quote unquote, baffled. And they're challenging and they're very frustrated. So there aren't that many of us out there trying to help them. And it's a lot of trial and error. There's not a lot of robust scientific research out there. So that's why I thought it was important to bring in 4 different opinions, people that are basically have shifted all their attention to trying to help these people. And first, we're going to talk to Dr. Peter McCullough, who renowned cardiologist. He also has a show on America Out Loud News on Wednesdays at the same time. Also going to talk to Dr. Stuart Tankersley, another America Out Loud News host who comes on Tuesdays. Also talked to Dr. Pierre Corey, co-founder of FLCCC. He now has the Leading Edge Clinic, and all he does is treat COVID shot injuries. Finally, we'll talk to functional medicine specialist Dr. Molly James, another outspoken early treatment provider during the pandemic who has shifted her focus to treating the injured. It's going to be a great show. I certainly learned a lot. And we'll get started after the break.
Are you struggling with thinning hair or excessive shedding? I know I am. Discover Roots from the Wellness Company. It's a doctor-formulated hydrogel with 7 powerful peptides that help repair and restore visibly thicker, fuller hair. It also contains methylene blue, which boosts mitochondrial function and nourishes your scalp without any oily residue. Whether it's stress, hormones, or aging, this formula targets the root cause, literally. Visit twc.health/OUTLOUD and use code OUTLOUD for 20% off your first order. That is twc.health/OUTLOUD. Experience the science of hair regrowth with Roots.
Let's get real. Let's get loud on America Out Loud Talk Radio. This is a McCullough Report, and I'm Dr. Peter McCullough. But I want to put in a word about the Bear Bar. The Bear Bar, and we feature Bear Bar products on the America Out Loud Shop website. So go to America Out Loud Shop and get your discount. You are going to want to try the Bear Bar. Get a whole box. The flavors include the original, turmeric, spicy, and herb. Now, these are all natural, no GMOs, no artificial ingredients whatsoever. They're carefully baked and made in a facility in San Diego, California, under the watch of Brian Bowers, who I personally know. So these are, in a sense, handcrafted. They have great ingredients and all the natural ingredients that your body is going to want. Now, they're not a sweet bar. They are savory, meaning when you eat them, you get a great sense of satisfaction. I told Malcolm on our last show, you get a sense of feeling healthy when you eat the Bear Bar. I think one of the best applications is crumble it up, and you can put it on a salad, for instance. Probably the best salad topper I think I've ever had. But you certainly can eat it as a snack. Malcolm likes to eat them right before I come on our show. No wonder he's in such a good mood when he comes on with me on America Out Loud Pulse. So when you eat a Bear Bar, this is not like any other energy or power bar. This is healthy. The ingredients include baked kale, cashews, so many other wonderful products incorporated into a bar. They are slow baked and without any preservatives. And so, that's the reason why they can crumble a little bit. But, crumbling is what you should get in a natural bar, as opposed to a gooey, sticky, manufactured bar with all kinds of chemicals in it. You won't see a single chemical in a Bear Bar. Check them out. Go to America Out Loud shop and then search for the Bear Bar. Order a box. I'd suggest order a box for each one of the flavors now, so you get a sense of what they are. Non-GMO, gluten-free. That's important for me. I'm gluten-free. I know I can have any one of the Bear Bars and get healthy now. So let's get real. Let's get loud on America Out Loud Talk Radio.
Virus protection and immune boosting just got easier. Enter the Daily V-Stack. Using cellular absorption technology, we put vitamins A, C, D, zinc, and quercetin together with a multimineral complex for complete protection. The Daily V-Stack is basically an oral IV of 6 products, all in one, at an affordable price. Go to chemicalfreebody.com/outloud, get the Daily V-Stack, protect yourself, boost your immune system, and save 20% on your first order.
Well, it's high time Americans refuse to be pawns in the human chess game. Under the name of diversity, politicians divide the people in their quest for power. Well, diversity of opinion and expression is as American as apple pie. Now is our time, my fellow Americans. AmericaOutloud.news. Liberty and justice for all.
I'm delighted to have Dr. Peter McCullough, who I'm sure you all know, a cardiologist who has been a warrior during the pandemic and continues to help with vaccine injured. Thanks so much for coming on, Peter. Would love to hear your experience with the vaccine injured.
You know, Americans should know that the Biden administration spent over $1 billion on long COVID in the long COVID HHS research program. In not a single study did they evaluate patients who took the vaccines, and the vaccines are probably accountable for at least 70% of long COVID syndromes, according to Exner and colleagues. And not in a single study did they address the spike protein, which is the spine on the surface of the virus. And the totality of the literature suggests that the spike protein retained in the body after COVID, and certainly loaded into the body after the vaccines, is responsible for the syndrome. The spike protein causes the organ injury syndromes. It causes inflammation, causes all these other problems. So from my perspective, until we have research programs that specifically direct their efforts towards the spike protein and treatments that are directed toward the spike protein, everything around the spike protein is not solving the problem. And I don't know if you've, in your practice, found any inferences on the spike protein that you feel are meaningful.
Well, yeah, I totally agree with you. And really the only meaningful test I have found is the spike protein antibody level. And I do find it doesn't always correlate, but the majority of the time, the level of the antibodies tends to correlate with the level of symptoms. And certainly it's a huge red flag, because the people who have gotten the shots, their levels in my practice are 10 times higher than the people that never got the shots. I don't know if are you measuring spike protein antibody level?
Right. So I've measured spike protein antibody levels in several thousand patients. And recently a preprint manuscript from Dr. Henry Barnum in Louisiana has found exactly what you said. I think the number was about an 8-fold increase in spike antibody levels in patients who've taken the vaccine compared to those who just had COVID. But importantly, most people who took the vaccine was in 2021. So we're seeing very high level of antibodies now 4 years later. And so in a research collaboration with the Inmodia lab in Germany, we're sending samples there of patients with various antibody levels to see if they have measurable spike protein in the bloodstream, and do they have residual Pfizer or Moderna messenger RNA and other fragments in the bloodstream and in the tissues. And in general, if the spike antibody levels that we measure in the United States over 5,000, in general, they'll have circulating trimerized spike protein in the bloodstream. That's an important inference. Below 5,000, it may just be residual antibodies and the spike has been cleared from the bloodstream. Frighteningly, we are finding residual Pfizer and Moderna in the body now. I have one patient at 3.2 years after taking the shots, and we're finding it in other tissues. We've sent skin biopsies, and we found Pfizer and Moderna messenger RNA into the skin. So if it's distributed in the skin, it's distributed all over the organs, and this is years after taking the shots.
That is, yeah, you're the first I've heard who's taken skin biopsies. That's very interesting. So what are you doing to treat these patients?
The problem, in my view, and the doctors that I'm collaborating with, is that the spike protein is the problem. To my knowledge, there are no human enzymes that degrade the spike protein. There are no hepatic pathways or renal pathways that break down the spike protein. And so we follow the work of Dr. Tanikawa in Japan, who demonstrated in preclinical models that nattokinase readily dissolve the spike protein in cell lysate and intake cell models. He also demonstrated that if you take oral nattokinase in a capsule format, it does get into the urine, or get into the bloodstream, And so there's very good pharmacokinetic data. That's one of the few supplements that for sure we know it works like a medicine. So nattokinase is used for sure. Another preclinical study with bromelain, which is a family of enzymes derived from pineapple, again, an over-the-counter supplement, we add that. And then beyond that, we use an anti-inflammatory supplement called curcumin, which in randomized trials has shown to block inflammation from the spike protein. In fact, it improves long COVID symptoms in randomized trials. So the McCullough protocol-based spike protein detoxification was the first publication in 2023, combining nattokinase, bromelain, and curcumin. And then based on additional data, there was a second paper in the Springer Nature Curious Journal of Biomedical Sciences using this combination, and we have one outcomes paper in a single patient who's had certainly a reduction in the spike antibody levels and improvement in symptoms. My clinical observation is among thousands of patients is the vast majority do drop their spike antibody levels and improve symptoms, but the time course is about 9 to 12 months. Occasionally, I have patients that just don't budge those spike antibody levels and they don't improve. But I agree with you that the spike antibody levels is a reasonable correlate for the spike mass in the body, and it does relate to symptoms. A safe level in the literature and what I'm seeing in my practice is under 1,000. So if I have somebody under 1,000 on the LabCorp Roche Alexis assay, we know we're in good shape. So clinically, I think everyone needs nattokinase, bromelain, and curcumin. The question is, what's the dose? And so the dose that we're working with now, let's take nattokinase as the principal component, is 4,000 fibrinolytic units twice a day on an empty stomach. And that can be advanced to 16,000 units twice a day on an empty stomach. And that's what Jordan Vaughn is using at the Vaccine Blood Clot Center in Birmingham, Alabama. The safety limit for nattokinase, we estimate from the published data, is about 80,000 units a day. There we're probably way over the line. So I have, and even in patients on blood thinners like Eliquis, Xarelto, Pradaxa, warfarin, I have advanced the doses to 4,000 twice a day and even 8,000 twice a day.
Okay, great. What about somebody who's maybe prone to GI bleeding or has some other propensity for increased bleeding? Do you have to limit who can take it at all?
The patients I worry about the most are those who are on aspirin and those on thienopyridines like clopidogrel or prasugrel or apixaban. And there we may actually have to down adjust the aspirin. Now, in thousands of patients, I've only had one serious bleed, and that was a patient who had liver disease, who actually did have a GI bleed from esophageal varices, but it didn't require transfusion, didn't require surgery. We simply stopped the spike detoxification, and he did fine. Now, let me say that this enzymatic approach does directly address the spike protein, and we have, a strong belief that that's the core problem. But there are some other approaches that are out there. One is using augmented N-acetylcysteine, and that's a molecular form of N-acetylcysteine, an antioxidant that may denature or separate the trimerized spike protein, or it may unfold the spike protein to allow some type of hepatic clearance. That's the theory. There's a company in Europe that's advancing the product and a urinary spike level that purportedly is measuring spike fragments, but all of those data are forthcoming. None of that has met peer review regarding spike detoxification. But that's another thing I am adding clinically in my practice. And then I have to mention Dr. Shirasawa in Japan, who has, in a single patient, I think very meticulously proven that a blend of enzymes has dissolved vaccine blood clots in the carotid bulbs of a man who was, having impending stroke. And he used a course. Now, this is interesting. He blasted the patient with products actually from a Houston supplier of nattokinase, bromelain, curcumin, lumbrokinase, sereptase, papain, and a whole variety, curcumin, a whole variety of other products. I think it was about 12 products that he used 3 times a day. Wow. So the enzymatic approach is one. Now, I do believe prescription drugs play a role, and this is ultimately how I've sorted this out in my practice. If there is a clinical sign that there is the presence of a reservoir of replicating SARS-CoV-2 virus. People have had COVID. If we think the virus is still in the body, and there was a GI study in children finding the virus was still alive and replicating about 5 months after the infection in the GI tract. They took biopsies. And then the Chertow study, which is the NIH autopsy study, showed even up to a year after infection that the virus was alive and it was replicating in the skin, the eyes, and almost all the organs. So when we get COVID-19, we don't all just clear this virus away. So there should be a clear role for, an antiviral like ivermectin. So what I do is I try to sort patients out. So if they've clearly had, well-documented COVID-19 and it's within a reasonable time frame, within a year, or if they have signs and symptoms, if they have intermittent fever, night sweats, any of the craniofacial syndromes, lancinating headaches, parotitis, visual or any type of sensory losses, hearing, visual losses, persistent pulmonary findings for sure, and then skin rashes. Interestingly, skin rashes, because of the Chertow data, to me imply replicating SARS-CoV-2. I've found that patients do respond to ivermectin, and I put them on a 0.6 milligram per kilogram course for 90 days.
Oh, okay. That's great. Yeah, that's new information for me because, I've been playing around with the dose, and what I'm finding is higher is better, even if it's not a, acute infection. Well, this has been. I'm sorry, go ahead.
Well, I just do it for everyone. Because, I think it's a targeted thing. Remember, ivermectin does not clear the vaccine spike protein. It's going to provide some temporary relief. What ivermectin is extinguishing the replication of the virus and entry into the nucleus. It does have some anti-spike properties. Let me just say quickly, if the blood ANA rheumatoid factor or anti-citrulated peptide is positive and there's kind of consistent arthralgias or neuromuscular symptoms, I use hydroxychloroquine. 200 milligrams twice a day for 90 days. If there is any forms of neuropathy, small fiber neuropathy, these kind of generalized peripheral neurologic symptoms, or even loss of mental clarity, I use a nicotine patch, 7 milligrams topically a day, typically for 90 days following Swiss data. And, I think there are some opportunities for other drugs. Let me just say briefly what I've tried and doesn't work. And that is Miraviroc and high-dose pravastatin. I've tried the Bruce Patterson protocol. I've found zero efficacy with that because it doesn't clear the spike protein. If I use ivermectin alone with no spike clearance, that doesn't work. In general, if we don't clear the spike protein, any of these other little symptomatic things won't work. Low-dose naltrexone I haven't found work. It doesn't work at all, so I don't use it.
Mm-hmm. Right. Well, this is very helpful. I appreciate it. And I'd love to have you back on when we can really dive into this a lot deeper. So thank you so much, Dr. McCullough.
Thanks for having me.
So now I have Dr. Pierre Kory, whom I'm sure all of you know. He was one of the co-founders of FLCCC, and he was instrumental in creating a treatment protocol during the height of the pandemic when we were all desperate for solutions. He's a huge hero of mine. Thank you so much, Pierre, for coming on today. And
Oh, Mary, it's a pleasure.
if you could just, we in the short time that we have, give us a rundown of sort of maybe an overview of how many patients you've treated with vaccine injuries and what you have found most helpful.
Yeah, so that's hard to do, but I'm going to try, Mary. So just real briefly, I've been doing this for 3.5 years. I opened the Leading Edge Clinic really with the intent of addressing this post-COVID vaccine injury syndrome. Really briefly, because I know you want to hear about treatments, but I want everyone to understand what that is. So I separate vaccine injury with post-COVID vaccine syndrome by definition. So vaccine injuries I think of as single organ dysfunction. So maybe myocarditis, stroke, heart attack, Guillain-Barré, things like that, anaphylaxis. The syndrome is really not a new disease. It's been around for decades. It's called MECFS, or myalgic encephalitis chronic fatigue syndrome. And there has been no standard treatment for that. Very little research. Many patients have suffered. They're failed by the system in that disease. And what that disease is, it sits on 3 symptoms. Those are the cardinal symptoms, which is fatigue, post-exertional malaise, and cognitive dysfunction. So those are the 3 pillars. And many of them are debilitated or disabled. Now, the treatments traditionally, if you read like position papers or review papers, I mean, the list of different medicines that have been used are like as long as my arm, as is my practice, because nothing works in everybody. The treatment approach for this disease, in my opinion, is repeated therapeutic trials. You got to find the hammer that hits the nail of that patient. And there are therapies which have higher response rates than others. So some of the best, and I'll talk about them. But in some patients, man, you can go to your 3rd or 4th trial before you get any movement, any response, any improvement. And it can be really very frustrating for the patient as well as for the provider. But as long as you show empathy and attention, you tell the patients you're going to work with them, it can be very collaborative and very productive relationship. But in terms of treatment, I guess I would say there's like first line, second line, third line, because like first line, I try to use the things that most commonly bring about some response. The other fascinating thing about this syndrome is even if a medicine works in a patient, I can't even tell them what it's going to help. Like some patients, like let me start with the most common one, first line on everyone. If I saw someone who's never really been treated, unfortunately, not unfortunately, but unsurprisingly, it's ivermectin. Ivermectin has broad mechanisms. It does a lot at inhibiting inflammation. It binds spike. And that's one of the reasons why we think it works pretty well. I would say about 70% of patients respond. The problem with that is the responses vary. Sometimes they're very minimal. They're modest. I do have a cohort in my practice for whom that's all they needed. I mean, it was like gangbusters. You give them ivermectin and they feel really a lot better very quickly. But unfortunately, that's the exception and not the rule. So I start with ivermectin paired with low dose naltrexone. That you have to titrate slowly. That takes more time to work. That also has numerous mechanisms, and that's kind of why I like it, because these broadly mechanistic therapies, just give you a high chance at probably, countering one of the many pathophysiologies that are triggered in these patients, which I'll skip for today. I just sort of wanted to describe this syndrome and jump into treatment. So those 2 are really helpful. Then mast cell activation is so common. A lot of these patients develop new sensitivities, foods, things like that. So dietary changes are good, as well as, we'll use H1 and H2 blockers like antihistamines, things like famotidine, Pepcid, mast cell stabilizers like cromolyn or ketotifen. That can be game changers in some patients. After that, then you have to talk about some of the hypercoagulability. And that's kind of been evolving. Like in the beginning, we were doing triple therapy. We were doing trials of triple therapy, a couple of weeks, see if it would work. We do like Eliquis, Plavix, aspirin, and as well as nattokinase. So that's kind of a foundation one. We use a lot of natto. I don't often see natto producing an identifiable response, but I think it contributes. And there's a few things that we do, like different vitamin supplementations and things that, don't really directly help, but I think are important to have like as part of their regimen. Natto is one of them. But with anticoagulation, we would see some pretty dramatic responses in quite a few patients. And then we discovered this anticoagulant, which you can't find in the US. It's called Sulodexide. Um, Been used for years, decades even, in like Japan, Russia, Europe. It's commonly used there. It's actually a prophylactic against clots. It's not used to treat clots. But it has all of these other mechanisms where it reduces like endothelial inflammation. And we first discovered it by adding it to triple.
Mhm.
And one of the reasons why we felt comfortable adding it is because it is ridiculously safe. There's tons of trials of Sulodexide. There's no difference in bleeding rates between control and treatment.
Hmm.
And sometimes I just use that alone. That's kind of my first line to address like the hypercoagulability and microclotting. And so we address that. Um,
But
you know,
how do you get
yeah.
that?
Oh, so there's well, through my clinic, there's a site. I don't have it offhand. Actually, I could look it up and try to give the site.
Mhm.
But what's interesting about that, it comes from Russia. It's made in Italy, comes from Russia, and the site that we buy it from actually now only takes crypto. So there's a couple of workarounds. It's bizarre, I'm telling you.
Love it.
Uh, but yeah, that's how we do it. And maybe afterwards, Mary, I can send you the link in case people are interested in getting it. But so then there's anticoagulation. Then there's just tons of different therapies that we use on occasion or my patients seek out. So you'll hear a lot of people talking about hyperbaric.
Mhm.
My issues with hyperbaric is that it's expensive. It's not always easily accessible. I have a lot of patients in rural areas or who don't have a lot of money. And so it's not always an option because there's quite a few therapies where it's not really relevant to the patient, depending on their finances and location. But hyperbaric has been really good in some patients, but it's struck out in a lot. I've had a bunch of patients who've done hyperbaric and it hasn't helped them at all. And so, but that's not to single out hyperbaric. That's just kind of one of my themes. It applies to any therapy that we try to use. Maybe now that I talk about hyperbaric, I'll talk about my experiences like in the beginning of my practice when I had really sick patients who I was really struggling with. I've sent them to these, I call them like multimodality clinics where they'll go for like 3 weeks. They'll get apheresis, ozone, hyperbaric, IV vitamin C, methylene blue, near infrared light. And I got to tell you, those patients did really well. It's expensive. They
Mhm.
did really well, got, pretty significant improvements. The problem is that they weren't sustained.
Really?
They often had relapse. And that's the other part of this disease is you can have patients doing great, making lots of improvements. Out of nowhere, they start to relapse or some new weird symptom develops. And I'm telling you, it's really frustrating for the patients and it's challenging as a physician. But some of those more expensive, like clinic-based therapies have been helpful.
What about,
Um,
well, real quick, are you checking for Epstein-Barr virus reactivation and treating for that?
I'm probably going to get killed for this. I am underwhelmed with Epstein-Barr virus testing. You
Mhm.
know, I think it's more of an epiphenomenon because like when you do those tests, those antibodies, they always come out in like not always consistent for reactivation. I actually don't really know that we know how to diagnose reactivated Epstein-Barr. Um, the patients with abnormal labs like that and those without appear very similar to me. And when I try to target Epstein-Barr, like with ivermectin, some other things, even DMSO, it's not clear to me that targeting it with also like monolaurin we use some broad like antivirals. I don't even see those patients responding. So, like, I got to tell you, I have a huge question mark on how big of a deal Epstein-Barr is. I know there was a paper showing that it's at a higher rate, but I haven't had a lot of success in addressing it. Um, oh, by the way, Suladexide has been helpful sometimes in tinnitus.
Hmm.
Um, and then, I don't want to say that I prescribe it, but I've been doing a lot of research on chlorine dioxide and writing on it. I have like a whole series. And the reason why I don't want to say I prescribe it is because I've really just been doing research on it. I've been calling for more research into it. I think it's a promising compound. But there's protocols all over the place, and many of my patients will go on a protocol, and that's been pretty helpful in those who've sought it out. So again, not that I recommend, but I don't interfere. It's actually quite safe. The protocol doses are demonstrably safe if you look at all the literature. Again, I've written all about them. Mary, I should tell you, I'm deep into my first draft of my book called The War on Chlorine Dioxide.
Oh, great. Wonderful. Yeah.
This,
I was with somebody over the weekend who's really into chlorine dioxide. I don't know if you know Jonathan Otto, but
yeah, I know Jonathan for sure.
yeah. So
Um,
I'm very curious to dig into that. Can we find that on your Substack? Where?
you can find many of the posts will be make up the book. So yeah, I wouldn't say the whole book is on my Substack, but most of the probably the most important science chapters, political context, persecutions of those who've tried to use it or recommend it. It's all on my Substack if people want to dig in now. But the book will be probably a month or two away.
Perfect. Well, thank you so
Um,
much, Pierre. This has been super helpful and look forward to your upcoming book.
yeah, for sure. Can I tell you about one more?
Oh, definitely, definitely. Yeah.
Because I got to tell you, this is the most transformative. I'll be writing about it soon. But I'm being mentored by two of I would call them the leading experts in the world. They're actually two psychiatrists. One his name is Rachel Wilkeson, and the other one's Mitch Leister. They're both from Colorado. They have transformed their psychiatric practices with the use of daily oral sublingual low dose ketamine.
Right.
Ketamine is transforming my practice of the vaccine injured, particularly with a lot of the neurological issues, the dysautonomia, the fatigue. Neuroinflammation, one of the cardinal signs of that is actually fatigue. And I've been using that now 3 or 4 months. It's a very specific protocol, titration, how we use it. It takes a while to kind of learn. But that's been really great. We're not doing what most of psychiatry is doing, which is charging a few $100 for an infusion every week for 6 weeks, like for depression, which is how ketamine's most used in the world in terms of treating psychiatric illness. But it is really good for neurological conditions. And I think we're at the leading edge of like a revolution of what ketamine can do for neurological things. We've seen in our collective practices, things like ALS, Parkinson's, early dementia, other neurodegenerative diseases. And then in my patients, a lot of their neurologic symptoms are improving. And that's kind of recent. Like I said, I've been doing this for 3.5 years, constantly researching therapies, trialing them. Again, many work. I'm looking for the ones that work the most and with the highest magnitude. And I got to tell you, ketamine is like really rising to the top in terms of one of my favorite and most helpful therapies.
That's very cool. Do you use a compounding pharmacy to prescribe?
Yeah, it's easy to get. I mean, there's tons of compounders that'll compound it for you. We use it either in liquid or in what are called troches, these little wafers. And it's daily. Most patients take it at night, and we titrate slowly. We use a few other supplements that go along with it that raise glutathione, things like curcumin, NAC, and MSM, which is a metabolite of DMSO. I also use a fair amount of DMSO for different pains, joint swellings, arthritic type conditions, and just generally all around. DMSO has a lot of really great mechanisms. So I have patients on oral DMSO protocols as well.
So not topical, just oral DMSO.
Both. I do oral and topical. Topical is for like the focal, aches and pains and bones and joints. And then oral just for kind of systemic, multi-mechanistic therapy.
Okay. And one other thing, you mentioned NAC. Are you using augmented NAC? Have you seen
Yeah.
that?
So I will tell you, in my practice, we're all a big fan of NAC. I will say my colleagues in my practice have had a lot of great success with it, or they have more patients that have a lot. I would put augmented NAC. It's been very helpful in some of my patients, but again, no single therapy is really killing it out there. But that's a really good one. I will tell you, it's a fan favorite in my practice amongst the team of us that are treating this disease.
All right. Well, wonderful. Thank you so much, Pierre. And I'd love to have you back on and we can talk about your book and dive into all of this a little more deeply.
For sure. Thanks, Mary. It's good seeing you.
You to.
Or talking to you, I should say.
Today, I have a variety of people who are coming on today to tell us what is working in their practice for the vaccine injured. And I'm excited to have Dr. Stuart Tankersley, who lives in Montgomery, Alabama, family practitioner, and he's treated about 1,000 vaccine injured patients with enormous success. Welcome, Dr. Tankersley.
Well, thank you so much, Mary Tally. It's great to be here, and it's great to share America Out Loud Pulse with you.
Yeah, and your show is, what day of the week do you come on?
We're on Tuesdays. Jordan Vaughn and I are on Tuesdays.
Perfect. So you told me, off the record that about 90% of your patients have seen significant improvement. And I want to know what your secret is. What are you doing to treat these people?
Well, it takes a lot of time, and it's really amazing. I think that looking at the technology they put into so many people, these shots, that I really have a strong belief that if you got the shot, you eventually will be hurt by it, or if not killed, unfortunately, because we're still in the greatest die-off in our country's history. We're still above the numbers, the projected numbers, if you look at the number of deaths between 15 and 19. And so I have a strong suspicion. So my radar is really tuned into this, is the reason I say all that. And so I have a laundry list of about 35, 40 questions, symptoms I ask of patients. And a lot of them have found me out from around the Southeast to word of mouth, of course, but those are easy, the easiest. And then the ones that were my patients, that have been my patients that got the shot, who don't recognize that they've been injured, I strongly encourage anybody that has to detox. And I start with, like you do, I've been doing the antibodies since I think August or September. And that's kind of my marker for how well they're doing or how long they need to be on it, kind of, because all this is in development. We don't know for sure, but so a lot of the patients, I'd say over half the patients, well over half the patients that didn't know they had an injury from the shot, but I convinced them to go ahead and detox, recognize that they are better in whatever regard after starting the detox. And I think that's very, very important for people to hear, because people are just taken for granted for 4 years of this torture they're receiving, that this is just a normal part of aging, when it is not. And so, sorry for the long intro there, but I start with, generally speaking, if they have ANA positive, I'm more inclined, quicker to do low-dose naltrexone and hydroxychloroquine maybe. But if they don't have an ANA, or if their D-dimer is not normal, or the thing that Jordan and I have been talking about the last couple of months, if they don't have a lot of pelvic symptoms that kind of lead me down the path of the pelvic vein clotting, that can cause, by the way, that can cause things like TMJ symptoms. You'll find that interesting, but we can talk about that later maybe. But if they don't have that kind of gestalt, if they don't have that kind of problem symptomatology, then just generally speaking, I'll start with a product that's made by Centurion, Centurion, BT Plus, which has several of the components of the FLCCC IMA protocol, including, I think lumbrokinase is probably going to be better, or septokinase is going to probably prove to be better in the long term. So it doesn't have nattokinase in it. That's one of the 6 or 8 components in it. And then, of course, ivermectin, and then a probiotic. I think Dr. Hassan's information on the gut biome is super, super important. And so I put them on that, and also put them on resveratrol. And so those are the things, the four things. So I'll, once again, ivermectin, resveratrol, the Body Quest probiotic usually, and then the fourth thing is the BT Plus product.
And for the ivermectin, what dose do you generally put people on?
That's a great question because earlier this week I looked at the FLCCC IMA protocol, and I've been using 0.2 milligrams for 3 or 4 years now. And they in their protocol, I was reading this week, it's 0.3. You start with 0.3, and if they tolerate it, and if they, I mean, almost everybody tolerates it, as you know. But if they get better, you might even want to move up to 0.6. They kind of indicate you should go ahead and go up to 0.6.
Yeah.
And I hadn't seen that before this week.
Well, I have noticed I had a very stubborn patient with neurological issues. When we doubled his ivermectin dose, he noticed a big improvement. So I was wondering about that. What have you found most helpful for neurological problems?
That's a great question. Dr. Diane Counts is a neurologist in our group of doctors here in Alabama, concerned doctors, and there are about 80 of us, I think. But she has been very helpful, and in the last several months has been advocating for a product out of Germany called Vedicinals 9, VED, Vedicinals 9, that, and really that and ivermectin and maybe a probiotic or whatever, but those three things, it is expensive. I think it's $170 online if your doctor doesn't sell it. But anyways, also low dose naltrexone. Yep, that's good. I just don't think you can get away from ivermectin. I just love the stuff. What else neurologically? I feel methylene blue has been helpful in a subset of patients. I'd say 25, 33%. I know Dr. Bregan, who does our podcasts on Thursdays, he has written recently about it, which kind of made me shy away from it. Mm-hmm. Seems to be a couple of other ideas, a couple of other things I consider. What are your go-tos for neurological problems?
Well, that's it. I mean, I just haven't found a great solution for the more severe neurological, and I have had some very severe neurological patients. And but I have you used augmented NAC?
Great one. I haven't. It's a part of the BT Plus. The NAC is. Okay. But I've watched those wonderful testimonies, and that doctor over in England that's talked so highly about it. And so I've told a couple of people to go buy it at a herb store here in town. But I'm this is so new, and it's exciting to be part of it like you are, you and Peter McCullough. It's exciting to be on the front lines, really seeing the benefit. And I can't wait till we try and all get together if we ever take the time to get together and try and tease out what really helps. I think Jordan's discoveries about the pelvic veins and the ramifications of that and mast cell activation syndrome is really going to be important. Beta histine is this ENT drug that Dr. Haslinger out of Maryland told me about. I think it has H3, histamine 3 properties that he's found successful in tinnitus. But, it's just great being able to help so many people. I'll share a quick caveat. There was a lady, very successful 60-year-old lady from LA who found me in Los Angeles, and she didn't want to get the shot. She got it. She got injured. Didn't want to get the second one, obviously, because of it. And her boss basically said, you got to get it. And she's been in bed for over 3 years. And she had been going to all these doctors at UCLA and Arizona, New York City. She didn't have any children, has, very wealthy lady, and senior executive in a national company. And so she found me, came in, and within a month after the initial treatment, she brought me 2 phone book size stacks of medical records. And so a month later, her first words to me were, 80% better. And it's been really, how rewarding that was. But what was really interesting, the week before, she had gone to see one of the her specialists at UCLA, and she wasn't in her wheelchair. She had walked in, she had been to the beautician, and he walks in the door and says, "You look better." She says, "I am." He said, "How come?" She said, "I found a COVID vaccine injury expert in Alabama." At which point his jaw dropped. He walked out the door, and as he was walking out, he looked back at her and said, "You're fired."
Oh, wow.
Yeah, this is an insane whirlwind these days. But that kind of recovery, I've really had maybe six or eight resistant patients who just simply haven't gotten better.
Right.
And that's to give hope. I say that not it's by the grace of the Lord that I've been able to see the reality of COVID for what it has been for 5.5 years. But the fact is that people can get better. There is hope ahead. And we know why we're doing what we're doing. And that's my biggest encouragement to the listeners.
Well, thank you so much for sharing this. Great information. And I hope everybody will listen to your show on Tuesdays at 4 p.m. Central Standard Time. Thank you, Dr. Tankersley.
Thank you so much, and keep up the great work.
So now I have Dr. Molly James, who is a warrior for COVID, all things COVID, and has been treating the vaccine injured. So I know, Molly, have you treated a lot of vaccine injured? And if so, give us, maybe the top 3-4 things that you have found helpful for treating these patients.
Yeah, I definitely have treated a number of vaccine injured. It's dwindling out a little bit because I think the people who have that have been routed other directions and haven't either connected the dots or they've given up. So we start all of our patients on a regimen of 4 things. So number 1, ivermectin, of course, fenofibrate as well. The purpose of those is to sequester the spike protein in an effort to bring that level down. I think there's people out there who are advocating that there's a detox. I'm not in that camp. I think we have to neutralize it and try to let our body clean it up the best it can. So those address spike, and then I use fish oil, and I use a product called Core Balance out of our store. It is a mixture of amino acids and things that are wildly anti-inflammatory to address that inflammatory and endothelial response. From there, we then look at the organ damage, and we have to address specifically. So we work them up. If they have fatigue, we work up the mitochondria. If it looks like it's tied to an infection, we work them up for Epstein-Barr, chronic Lyme, those kind of things. If it's cardiac, we're making sure we have all those cardiac testing parameters done. If it's neurologic, we have a lot of things to offer. So one of the things we found works really well with the neurologic issues is PRP, or platelet-rich plasma. So that's one of the things we incorporate down the road a little.
So is that done intravenously?
Correct. So we draw blood, we spin off the cells, the red cells and the white cells, and we inject back through the IV plasma and platelets. We know that this crosses the blood-brain barrier. I've had a patient who had neuropathy for another cause, and she had had an EMG before and after, and her neuropathy resolved completely. So we have anecdotes of pretty good evidence that that's resolving some of these small fiber neuropathies. Anecdotally, a lot of patients are getting better. They're getting their sensation back, or at least their pain is gone.
How many doses does it usually take to see an improvement?
Yeah, it's different. I ask people to commit to 2. It's a bit of an investment. The company asks that you commit to 4 because we have to hit that critical mass of addressing the inflammation. And sometimes 1 is noticeable, and sometimes 1's just not enough to make a dent in it. So at least 2, sometimes 4.
And it sounds pretty safe. You're just injecting your own, blood components, right?
They are. Yep. Extremely safe, very well tolerated. I don't think we've seen any adverse reactions from it at all. We've seen patients who have Lyme that go into a bit of a herx, but that's expected and part of treatment. So I wouldn't call that an adverse effect. And then I do have some patients who have the encephalopathy piece of it with the memory and the activity. And I have one patient who's been doing it now, probably 6 or 7 of them, because it's really starting to work the longer we do it. So everybody's a little bit different, but that one is one of my favorites for the neurologic stuff.
And have you used augmented NAC at all?
I haven't. I've looked into it and I don't understand what it offers over just regular NAC and milk thistle, which we use anyway. So I'm curious about it or would like to learn more.
And will you tell me more about fenofibrate? Because I'm not using that. I'm just curious what.
Yeah. Fenofibrate was actually part of my protocol during acute COVID. And I always wondered, what are we're doing, which piece is making a difference? And I had a number of patients who were being treated elsewhere that wasn't part of their protocol, and they came to us because they were getting worse or not getting better, and I added that. So fenofibrate binds the spike protein. It's also fibrinolytic and anti-inflammatory to some degree. So for those of you who aren't familiar with it, it's an old cholesterol drug. It's not a statin. It's in the fibrate class. Very well tolerated. And I usually, again, on the acute phase, we do it for a week or 2, up to a month. And in my long COVID or vax injured, we're doing it about 3 months, and then I usually stop it.
And then are you checking COVID spike antibodies?
I have a few patients who have requested that. I haven't seen the levels correlate with clinical response. So that's one I just haven't done just out of convenience because it doesn't change what I'm doing medically. But I have seen the exorbitantly high antibody levels, and you just have to know that's causing a lot of inflammation in the body when you're seeing antibodies that high.
Yeah. And then for ivermectin, what dose do you usually start people on?
Yeah. So in the COVID space, we start them on the 0.2 to 0.4 milligrams per kilogram. So 150-pound person would be like 15 milligrams twice a day. You could do 30 milligrams twice a day. I find about 5 to 10% of people respond beautifully to ivermectin. Everybody else doesn't notice much of a difference. I think it's always worth adding, and I think it does something even in those people who don't notice a huge difference. In our cancer patients, we're doing much higher doses of that, but we still start them low and taper them up. So
Right. Okay. And then one other thing that I've heard people doing is IV glutathione. Have you done any of that?
yeah, we use a lot of IV glutathione. I don't use that on its own per se, but that potentially it just helps with detox. One thing I didn't mention is EBU. So EBU is an ozone treatment, extracorporeal blood oxygenation and ozonation. What we do is we put 2 IVs into a patient. Blood runs out one side through a dialysis filter. It is not dialysis, but it's the filter that's used. And as it runs through the filter, the blood is exposed to oxygen and ozone. And then it goes through a UV light and goes back to the patient. We run that circuit for about for an hour. It treats about 2.5 liters or half the blood. And there was some evidence presented at the ozone conference that might be pulling spike protein through that filter. And it definitely helps with biofilms and other things that can be secondary to that. So it breaks up those clumps of red blood cells and oxygenates them a little bit better. So we definitely see improvement with that as well.
Is that something you have to do multiple times, or is it a one and done thing?
Usually it's multiple times. Again, it's individualized for each patient. Some people respond beautifully to one. It's once a week for 3 to 4 weeks potentially, and then you can do it less frequently as you're starting to recover.
Great. And then one other thing I thought of, what about hyperbaric oxygen?
Yeah, so the hyperbaric oxygen works beautifully for patients. There's a couple of main reasons. The people who have shortness of breath. So there's a subclass of people who just really have they struggle to breathe. They have dyspnea when they start to do things. It works really well for them because it oxygenates and reduces inflammation in the lung tissue. It also works really well for some of the people who have neurologic issues. headaches, fatigue, brain fog, things like that. I haven't seen it work well for other things like the cardiac stuff. I haven't seen it work well for that. But if you pick the right people and do it, 2 to 3 times a week, you can see a big difference.
Okay. And sorry, one more thing. You say you're not using nattokinase, or do you use that?
I tried it at the beginning, so that was part. I mean, I've tried almost everything you've heard of, and I've narrowed it down to these things at this point. So the nattokinase, I never had anyone tell me it really was life-changing for them when they added it to their protocol. And in the same publication and presentation at the Ozone Conference, what they found is the nattokinase may be breaking up the spike protein and actually increasing the inflammatory components circulating in the bloodstream. So I have avoided that at this point.
Okay, well, wonderful. This has been super helpful. And is there anything else you'd recommend, or if we covered it all?
I think we've covered the highlights. Basically, if you're still struggling with this, a lot of people get frustrated. It's a huge investment and it's a huge time investment, and people start to lose faith, if you get too far down the road. And I would just advocate that there's probably somebody out there who can help you, and keep looking and keep searching for people who have options for you.
And tell everybody where they can find you.
Yep. So James Clinic, we're at jamesclinic.com. You can follow us on Twitter. I'm at MallsJames or at James_clinic. You can find us on all the social medias under that handle.
And which states do you practice in?
We have clinics in Michigan, Iowa, and Missouri.
Great. Well, thank you so much, Molly. Great to see you.
Yep. Thanks. Great to see you too.
That was very interesting because all 4 had different approaches. And it proves to me that we need a lot more research. We need a lot more collaboration. And these patients are very complicated. Results are slow going. So if you are injured, just know that people are seeing improvements, but it's not an overnight thing. It may take a long time. It may take, as Dr. McCullough said, 9 to 12 months at least. I've seen some dramatic improvements, but for the most part, I've seen just gradual improvements. My approach, I always, or almost always, start with ivermectin, and that to me has been the single most effective therapy that I've used. But unfortunately, it's not enough for everybody, especially the patients with severe neurological injuries. Those are by far the most challenging patients to treat. But, we're still working on this, and I'm going to do this again with more experts because I found it very interesting and insightful and helpful. And if you're injured and you found something that's really worked well for you, we would love to hear about it. Let us know, and we'll try to feature that on our next show. Thanks so much for joining. We'll see you next week on America Out Loud News.